So if you look at the theory of collusion, right? What we in palliative care have always been talking about is the communication conundrum, and it's defined as a secret or implied understanding between clinicians and patients / family members to conceal information. So basically what happens is that there are three types of collusion. One is that the relative tells the doctor not to tell the patient, which is quite common in our country. The next is that the patient tells the doctor not to tell the relative, which is perfectly fine because of patient autonomy and confidentiality. And the third type of collusion is when the relative tells the patient not to tell the doctor. That can happen sometimes when the patient is not forthcoming of all the information. Now, this is a communication conundrum, but there is also an interesting concept or a psychodynamic concept. And this psychodynamic concept, okay, is the fact that there's another interesting paper by Stiefel, which I have also sent, where he and his group of people working in Switzerland and in Japan said that collusion also depends upon unresolved psychological issues in the mind of the doctor. And therefore, they have classified collusion into different categories, okay, where it could be silent, expressive, behavioral, and it could be positive or negative. Positive collusion is that if the physician agrees with what the patient thinks, then it becomes positive. And there are times when it's a negative collusion where the physician does not agree with what the patient says. And therefore, in this paper, they have said that palliative care physicians like us don't have the faintest idea about what collusion is. And we keep on talking about it to say that it is a, attempt on the part of the family or the thing because they are concerned or there is love and affection for them, which we keep on talking about. But he believes that there is something much more to that. Now, whether that is really important or not is something that we really, have to see practically whether it is going to make any effect. Yes, next slide. Now you're fine, Nisha. Now, next slide, please. Right. So, if you look at the prevalence of collusion in Indian studies, of course, my guru Santosh Chaturvedi and his colleagues have done some excellent work on collusion and in communication. And there are various percentages of how collusion is predominant. Now, if I look at the experience that we have at our hospice in Bengaluru, 25% of patients who get admitted for palliative care when their disease is so advanced, they are either not aware of the diagnosis at all, or they are not aware of the extent to which the disease has been. And it becomes a very difficult thing for our counselors to work with the families. And therefore, we do need to realize that collusion is very, very prevalent. Next slide. Can we have the next slide?
Yeah, sir. Doing it. 1 minute.
Okay. So if you look at the predictors of collusion, okay, there are a number of predictors of collusion, okay. One, of course, is the issue of culture. How are we, we are totally different. And I always say that the society in previous slide, please don't change. Okay, is that we as Indians we are a collectivistic society. So this whole business of patient autonomy does not necessarily work in the same way that it works in the West. It's very common for us that women are not really in charge of what happens to them. In many instances, it is totally dependent upon the male members of society. And they are the ones who tend to take decisions. Then, of course, age. Studies say that as you grow much older, you tend not to take your own decisions. And here it is even more important in our country because of the fact that if you're a senior citizen, you perhaps don't have income, and what treatment that you are supposed to get or what information that you need to be told is usually filtered by the family members. Educational qualification, of course, is quite obvious. A lot of people think that it is much easier to talk to people who are very well educated. But I'm sure that many of you people at the grassroots level will find that perhaps educated people, tend to be less trusting. Perhaps they keep asking more questions, while a person who is not so educated, okay, perhaps will agree with whatever you would say. But we have to be very careful that we give information that is required in the right way. Of course, socioeconomic status. Now, if you look at the whole thing about the family, right? Obviously, we all know that families are totally different, and each family has got its own dynamics, which are dependent on lots of things. Now, one of the papers that I read long ago was very interesting when they talked about what is known as the attachment theory. And this is based on, of course, the theory of how a child and a parent bond. And there are different type of families that are there, okay? There is one type of family is what they call as a secure relationship, where they are very happy to be comforted by others. There are some who are self-reliant, who do not want, they will not trust others, but they would like to form their own strategy. Then there is, of course, the support seeking, when people require support and they keep reaching out to people. There are others who are cautious. They want support, but they're not willing to trust people very easily. And of course, in a family, if there has been a death in a similar nature, or there's a disability, or if there is, there are reasons for emotional vulnerability, all these factors will affect, collusion, and you can anticipate that collusion can occur. Next slide, please. Now, if you look at the type of collusion, right? There are two things, and this is a wonderful paper by Dr. Chaturvedi and his team. Now, many times we say that it is a conspiracy of silence, okay? And that is, we do not tell people, okay, about giving the full news. But what is equally important is what is known as a conspiracy of lopsided communication. That even if we tell them something, okay, we tend to concentrate on what is called as a recovery plot. We will filter information, and the conversation tends to be more towards the fact that, this is what's going to happen, this is the time you're going to get better. And the whole idea is that you should instill hope in a person, and therefore it is very, very filtered information, and therefore is lopsided. While on the other hand, you can have partial versus complete collusion, in the sense, again, it's whether you give all the information or you don't give all the information, but you give information in a way that would make the patient happy, and not necessarily giving him all the information that he should ideally get. Next slide. Now, if you look at the reasons that the family has, of course, this is from a study by Lowe et al., where, there could be a loss of hope, it could cause depression. Some people feel that it will hasten the progression of the illness and death. The moment the person comes to know about it, he will die soon. Some people believe that it's an increase in the risk of suicide. Of course, psychological pain. And very, very important is that it will cause conflict in family members. And that is something that we have seen. I'm sure people who have been, actually dealing with it at the grassroots would realize that, the family dynamics come in a big way to decide how much of information to give to the patients. And of course, there is this thing about denial among family members. So this is just from a particular study, just to illustrate what is there in the literature. But each one of us in our own circumstances would realize that these are some of the very common reasons why family members will ask the doctor not to tell the patient. The common thing is that I know my brother, or I know the patient well, and he will lose hope. Next slide. So again, from a paper by Roshan Sutar et al., including Dr. Chaturvedi, when they looked at this, these are some of the caregivers give the reason. That is that, the patient will break down, will be sad, will not cooperate for treatment. They may say, okay, if this doctor is not willing to to give me the hope, I'd rather go to some other hospital. They may think about their death, stop eating, drinking, whatever, maybe angry. And of course, as usual, tension will accelerate illness progression, which is again a very common thing that people are worried that giving information is going to make the person probably die sooner than otherwise. Next slide. Now, if you look at these, reasons for collusion that we have, okay, it's a little busy slide, but if you look at it, there are various reasons. You look at it from the point of view of the staff, the patient, the family, the environment, and very important, the skills and training of the people. Now, what happens as far as the staff is concerned, particularly, for example, in India, the doctor's in a bit of a hurry. Perhaps he's not very keen on facing the emotional impact that might befall the patient. And then the nurses will tell very clearly that we are not supposed to talk to the patient at all. Okay. And then, of course, there are other things that are there, like, for example, they are not given a specific role and responsibility. They feel that the family has a right to decide. And therefore, who are we to say that they need to be told about it? Language problem, of course, is always there. Some staff members feel that they do not get the support from the seniors in their team. And of course, the tendency to pass the buck to others. While in the case of the patient could be in denial. And many times, we really don't bother to ask what the patient really wants. What are the choices that he needs to make? And then, of course, we will say that the patient will lose hope and the usual other stuff. In the case of the family, again, I've mentioned this before. There's no point in reading out all these points. But one of the things is the fact that many times, they do not really know what they should do, how should they talk about it. And of course, the environment and the fear that, are we going to get into trouble with the law is there. And most important is that most of us really do not know how to handle such things. And therefore, there is a lack of skill and training. So all these are some of the factors all come together, and ultimate result is that the patient is not given the information. Next slide, please. So if you look at the cost of collusion, it is quite obvious. We have to the patient, well, his autonomy and self-determination is affected. You are not able to take proper consent because you have not told him that. Then the confidentiality issue is there, and the distrust at the end of the day. And this is what I have found in patients at our hospice. When we ultimately do talk to the patient and we do let them know, there are many times instances where the patient has got very upset with the family members or with the doctors for having kept them away. And therefore, they are not able to make appropriate decisions that are required. To what we say, that we all have an agenda in life, and many times we are not able to fulfill some of those items because we were not told in time. And as far as the family is concerned, deceiving somebody is very difficult on their emotions because of the fact that you have a deep sense of guilt. And very, very importantly, that there is no environment for open, honest communication. And I can give you enough practical examples. We don't have the time for it to show that, when there is, we call that as refusing to acknowledge the elephant in the room. And it's a very tense environment. Each person, is very, very careful, very guarded, does not want to show emotions, but it becomes very obvious on the face of the person. And then, of course, issues like, what the person would like in terms of end-of-life care, etc., just cannot happen. And as far as the clinician is concerned, of course, is the fact that it breaks down the sense of trust that is there between the doctor and the patient. And sometimes there is non-compliance of treatment, which I will be referring to in one of the cases that I have given. So can we have the next slide, please? So again, it's similar to the previous one, where these are some of the emotional impacts of collusion, an uncomfortable relationship, and there's always helplessness and anxiety because you're not telling the truth, and there is fear and suspicion. So this is something that is quite obvious. It follows in the previous two slides also talk about the same thing. May I have the next slide, Nisha? So we come now to a little bit of the ethical aspects of truth telling in a way. And in fact, I had to write a small piece for my Rotary Club on what we call as a four-way test in Rotary, when it is the truth. So there are certain ethical theories that are given. One of them is the theory of utilitarianism, which basically says that the end justifies the means. And therefore, if it is that you would like the patient to know all the information, and that is going to help that person to take the necessary decision, then good, it doesn't matter. You can break the bad news. While in the case of, if you look at the theory of deontology, which talks about the moral worth of every act. So is lying, is it moral? No, it is not moral. And therefore, you have to be truthful regardless of the consequence. So obviously, we cannot use only one or the other of it independently. And then, of course, we've got the four ethical principles that Beauchamp and Childress talked about, where it's patient autonomy, beneficence, non-maleficence, and justice. And how are we able to achieve a balance about it? Now, again, if you look at truth telling, okay, there are some important sort of theories or names that are given, okay. One is empirical truth, which is obviously based on scientific knowledge. Then you have the ethical approach to truth, which looks at the moral values that are there. Then the aesthetic aspect of truth, and that is something that we will come to realize when we converse with the patient. What is it that is important to that person, and how do we actually talk about the truth? Personal knowledge is knowing the person well with a combination of aesthetics. Then, of course, language is very, very important. The type of words that we use is important. Depending on which part of the country you are from. Now, I trained in Mumbai, and I had lots of my patients who used to come from Bihar and UP. And, those of you who are from that part of the country know that, for example, even for simple pain, where we would probably, say dard, but, there is the balbalahat hai, sansanahat hai, pirahat hai. And then you have mitha dard. Okay? So you need to understand the nuances of the language. There are cultural issues, and of course, there are also the spiritual aspect of truth telling. So these are some of the theoretical aspects that one might want to read and understand purely from the theoretical point of view, so that it helps you when you're dealing with collusion in your day-to-day practice. Next slide. So the legal perspective of this, right? I consulted my colleague, Dr. Dhwani Mehta, who's working with us on end-of-life care. And she basically said that you cannot withhold information because if you're taking consent, it is understood that you are, you have told the patient everything. And I will not be surprised if in the course of a few years, if it's not already happened, that doctors will be sued by patients for withholding information. And therefore, we need to make sure that we are very careful about it and don't just agree with whatever the relatives of the patient say. No doubt their intentions are very honorable, but I think we need to handle the collusion. Next slide. Okay, so who is the person who's taking up this case now?
Good morning, sir. Good morning, sir. Myself, Dr. Krishna Priya, junior resident in AIMS, sir.
Yes, Krishna Priya. So can you first of all have your video on, please, so that everybody can see you?
Yes, go ahead.
Yeah, and please go ahead.
Yes, sir. Avinash, Avinash male, 24-year-old juvenile diabetic under the care of Dr. Rao for over 15 years and gets admitted at the emergency in severe ketosis. Dr. Rao is shocked that a very compliant Avinash is in this condition. His sister is in extreme distress, explains Dr. Rao. Please save our family. We got him married 2 weeks ago, and we did not tell his wife and her family that he has juvenile diabetic. He went off on his honeymoon and did not take his insulin. Please do not tell his wife that he has been your patient for many years, and can you avoid mentioning juvenile diabetic in the discharge summary? Of course, you can declare that he is diabetic.
Yes. So I would like to ask you now, it's a very simple, and this is not something, an imaginary story. This is what I was asked by a diabetologist many, many years ago. And it's very clear that here's a guy who's a juvenile diabetic. His family has lied to the girl and the girl's family. And now he wants the doctor to, again, be dishonest and to tell a lie to the wife of the patient, as well as to write in the discharge summary that the diabetes was detected right now. So how would you handle it?
Sir, in this patient, the history, now the problem is told by her caregiver, like her sister, his relative. So we need to address her feelings, like she is very anxious and on the edge now.
Right.
So we have to address her feelings, and so we can wait for the patient and as well as the attender to calm down. So then next week we can explain to her that as this is a feature of the disease, that such situations can occur in the future also. So
Now, let me interrupt you here, okay? Now, okay, you are the doctor, and I'm imagine that I'm talking on behalf of the sister. I'm the sister, right? So I keep on saying that, doctor, please don't tell my brother's wife that he had diabetes earlier, okay? And then you probably, as a doctor, would say, I cannot lie for whatever reason, right? What you said, this is a long-standing thing and all that stuff. Then I would say, but then if you were to say that, then the marriage will break. So what would you then say to the sister? Hello, I'm asking you. Answer the question.
What happened, KP? Answer the question. KP, Prashna Priya. Your mic is muted, I think. We can't hear you. I
Arun,
think
would you like to take...
anyone else. I think she is scared of this.
सुषमा, आप सब लोग को इतना डराती है क्या?
No, she is scared of this question, that how to handle the wife of this boy.
Okay, anybody else from among the MD students can unmute, please. Arun, decide karo.
Yes.
Anyone else wants to answer the question? Please come forward. Otherwise, sir, please, our Krishna Priya is logged out actually. I think I will admit her again and see if she can. Yeah.
Not to worry. Okay.
She logged in. She has come back.
I'm not seeing the chats, but let me, for saving time, I'll let...
Good morning, sir. I'm sorry, sir. The power went off just now.
Okay.
I'm extremely sorry, sir.
No problem.
Sir, as I was telling, sir, the another feature of the disease is like it can happen. The recurrence is very common. So,
also, chodo, Krishna Priya.
yes, sir.
Now, what I'm asking you is this, right? The doctor has got a very valid reason. Whatever you say, disease, falana, etc., right?
Yes, sir.
The sister says, I am doctor. If you were to tell the truth to my brother's wife, because we have lied to her,
Yes, sir.
the marriage may break.
Okay, sir.
What would you then say to the sister? Hello.
Yes, sir. Yes, sir.
What do you say to the sister?
Uh, sir, even if we can convince the sister that that may not be the scenario. That is one of the things that she is expecting, but it may not be
Suppose
the.
it happens. You mean to say, just imagine yourself, okay,
Yes, sir.
right?
Yes, sir.
If you were in the position of that girl,
Yes, sir.
okay, that somebody tells a girl a lie, a major lie like this,
Yes, sir.
okay, would you be the pativrata stri and say, oh, mere nath, jo bhi hai, or there is a possibility modern girl may say get lost, divorce, kya karoge फिर?
Uh, so we can explain the problems, like if you do not say, that is having a major problem, rather than uh, concealing the truth from the wife. So it's better, the best option is to tell rather than not to tell, because
Yes.
it's the disease
How
is
do you
not
handle it?
curable.
What do
As
you
a
do?
um, sir, I will calm down the sister, as well as the patient also. After getting stabilized, we will say that hospital and with the doctor will be the best place to disclose a thing, because his wife will be having a lot of queries regarding the disease. So then and there, the things can be discussed there itself, so that it will not cause a lot of confusion in the family. So I think, sir, this is that we can
So
convince the.
ultimately, what are you going to do?
Uh, Sir, I will try to convince the family as well as the patient to disclose the information to the wife.
So
So,
who will disclose the information?
um, the clinician can we can in a group, sir. We can make them all sit
Okay.
and.
Okay. All right. So I want to move on. So if others don't mind, of course, I opened the chat window and I saw a few things. My friend Ganpati said, palliative care people will come in the end and they don't know. This is not necessarily a communication of a palliative care thing. The patient is otherwise well. It's routine handling collusion and regular medical practice. So let me summarize with your permission, Arun. Okay. This was a question that was asked to me many years ago. I went around the country doing a few sessions for Novo Nordisk. They were doing some study on use of insulin, and a diabetologist in Chennai asked me this question. So what I would think is one possible approach is the fact that if I'm the physician, okay, I understand the problem that the family is facing. But I need to tell the sister that as far as I am concerned, for whatever reason that have already been mentioned by Krishna Priya, okay, and the fact that ethically I'm not willing to lie on the discharge summary. What I would probably do is that right now he's sick, let him recover, but that I would then go and sit with my patient whom I have known for a long time. I would encourage him to be honest, and I would ask him to decide whether he or his family members, whoever, were to break the bad news to the wife that this is not diabetes that has occurred just now, that was not detected before, but that it is juvenile diabetes. And therefore, in a way, the family needs to confess that they have lied. So what I'm trying to say here is that as a clinician, I should not hold the high moral value, and say, oh, you have lied, and therefore serves you right. Or, oh, I'm so worried about the marriage, the thing is there, so I'm willing to collude with you and therefore tell a lie, because ultimately my professional reputation will be at stake. Okay. So this is an example where you are having an opportunity to prevent collusion from occurring. And that is what is this particular example. Can we move to the next slide? Okay, so how are you going to actually manage the collusion, right? So basically speaking, if we look at the thing that collusion, generally speaking, okay, at least from the palliative care perspective, is the fact that the relatives are, having very good intentions, but they would like to protect the family members and therefore the patient. And therefore, we need to acknowledge the fact that, yes, I do agree with you that this is what your intention is. And therefore, you validate the feelings and the motivation of the family. And you have to respect also the patient's right to know. Next slide. So here is a wonderful thing, where you talk about acknowledging the feelings. And therefore, this is the friend's approach. You acknowledge the feelings. You look at the reasons for collusion. You can reason out the misconception, and you reassure. No, don't leave. Go to the next slide, please. Keep to the same side. The next thing is the I, where you identify with the intention of the family member. Then you explain the pitfalls of escaping, that is, of not telling the patient. The N of the friend is now. You should do that now. It's to discuss the pro and con of not telling or of silence. The D is discuss about the patient's feelings. And this is important, okay, that particularly during deterioration and also the resultant damage that can be done, and the delay, is it worthwhile to delay it? It's delay wise. And then of course, the S is to stabilize the family dynamics and to negotiate the contract. So this is from a paper by Roshan Sudhar et al. With Dr. Chaturvedi also there. I have forwarded all these papers to you people, to the MD students, and anybody else wants it can email Nisha and get the papers. Next slide. Next slide, please.
Okay, sir. Moving.
Okay. So if you look at this as an imaginary conversation, you acknowledge by saying that I can see that this is a terrible ordeal for you. Look at the reasons. Like you told me that your mother would not be able to bear the news of having cancer. Can you tell me what worries her the most? In which case, the family member can say that if she finds out, she will collapse or she will die. So then the doctor says, your mother better than me. And you may be right, but are there any reasons why you think that? You may say that I feel that she will do that. There is absolutely no particular reason for that. Next slide.
Moving, sir.
So the intention is that I understand that you do not want her to be informed. We will respect that. And we also will share your desire to help your mother, save her from greater distress. But you look at the pitfall of escaping. But tell me, how does this, carrying this secret affect you? And obviously, very likely the patient may say it's terrible. I'm tense all the time. I'm always constantly alert that she does not come to know. And therefore, I'm avoiding her and spending less time with her. Next slide. Discuss the pros and cons of not telling. Because you're anxious and you're not meeting her, how does she feel that you're avoiding her? And then, of course, you stabilize the dynamics and negotiate the reassurance to say, can I ask your mother what she thinks about it? Does she know about it? And then, of course, to help the person to break the bad news. Next slide. So this is a slightly busy slide. I'm not going to go through all that, but it is basically that if the family wants the patient to know the diagnosis, whether the family wants to do it or the clinician, they want the clinician to do it. If the clinician is asked to do it and if the patient is mentally competent, you can go ahead. But if the family says that they would rather like to do that, are they aware of how to do it? And you need to give them guidance. But if the family doesn't want the patient to know, then you go through the whole thing of asking as to why you don't want him or her to know about it. And then go through all those questions that we had already discussed about, and explain to them what is the importance of being honest about it. And ultimately, tell the patient. Let me, at this point of time, interject. Some of you may know, but one of the main reasons why I gave up, my life as a surgeon was because of the fact that I was very sick. And, I've had 3 kidney transplants and bilateral hip replacement, lots of other things. My wife was the first donor. And the graft got thrombosed. And my treating team did not tell me that the nuclear scan showed an absolute silent transplanted kidney. But I could see on their face. And you cannot imagine the amount of distress that I went through. I would have been much, much happier had they told me the truth. And therefore, this is something that I'm coming out with practical experience. So this is a chart of how you can go about it. Next slide. So what are the strategies? Ensure that the family is fully aware of the diagnosis. Explain the reasons and problems of the collusion. You could, maybe have a pamphlet or something of that sort. Also tell people how you're actually going to break the bad news. That it's a well-researched way. It's done with a lot of compassion. Offer to help to break the news yourself. And if the family says, what happens if the patient were to break down or this or that, to say that, yes, these are reactions that will happen, but ultimately the patient will be able to cope with it, and say to it that we are always there and available to you to support you. Next slide. Then, of course, as far as the staff is concerned, now you will be surprised that at least in the early days of Karuna Share, and I'm talking about more than 21, 22 years ago, we had some of our staff members who felt, is there any need to tell the patient about, about the fact that, particularly at a stage when he's in palliative care. So we need to make sure that every member of the staff is on the same page as us. And therefore, we need to create awareness. We need to, show them the importance of assessing the collusion and the importance of training. And as far as the organizational strategies are concerned, we need to make sure that we have a protocol that is in place. And also the importance of family meetings. Some of our, of my colleagues, I think, are listening to this talk, but we have, a very, very well set protocol, as I'm sure all palliative care units have, of how do you deal with collusion and how do you deal with the family members. Because we need to take them on board. We need them to be partners in our effort to look after the patient and not treat, a family member as an adversary, but to take them along with us. Next slide. Okay, so this is the second case, all right? And I would like, I think it's Prajakta who's supposed to discuss this case.
Yes, sir. Good morning,
Yes,
sir.
Prajakta, please go ahead.
Yes, yes. So this is a case regarding Raju. He's a 13-year-old schoolboy who was diagnosed with lymphoma. His parents were very vehement that the doctors must not disclose the diagnosis to him. The parents were very careful that Raju is not alone when anybody talks to him, and they made sure that they took him to a hospital where the words cancer treatment was not displayed. So after the first round of chemotherapy, he refused to take the next round, and no amount of convincing made any difference. The mother was very distressed and reached out to a psycho-oncologist.
So how would you handle this situation? And, does collusion need to be addressed or broken every time? So what would your approach be?
So, first, we need to create an atmosphere where we know that the family trusts us and they understand that we are there to help them. So, first we need the assess the relatives' understanding of the disease, and also for the reasons for why they are not telling the patient. So, because they know the patient better than us. So, if at all, so we can tell them what are the consequences and harms of not telling them, and also we need to tell them that if we don't tell the patient, and since in this case he has stopped the treatment, so it is very difficult for us to further give him any help him, and also that the patient is of the age of where he can understand most probably that whatever he's here for in the hospital, he knows that he is suffering from some disease, and he might be fearful, and that's why he's avoiding this. And
okay, so you've generally got the trend. Let me tell you that this was a case that was recounted by very, very senior psycho-oncologist in Bengaluru, by the name of Dr. Brinda Sitaram. And she might not remember if I tell her this, but she spoke about it in a Rotary meeting that I attended years ago. And the story was that this boy, was taken to Kidwai Institute of Oncology because the word cancer treatment is not written. And so what is the approach now? Here, unlike the first case, collusion has already occurred, right? So what are you trying to do? You need to break the collusion because of the fact that the patient is not taking treatment. Number two is the fact that it is causing enormous amount of distress in the family. The mother would not allow any of the friends to come nearby, would not allow him to be alone because she was afraid that somebody will tell him the truth. So what you would normally do in such a situation is, as you rightly said, talk to the family members and then ask them as to what has been happening. The next thing is you will say, how sure are you that the patient doesn't know? Because in many instances, patients know about it and they are playing this drama of mutual pretense. And therefore, the psycho-oncologist negotiated with the mother and then spoke to the boy and said, tell me, how are you? So the boy, I believe, said, he says, auntie or madam, I've got cancer. So how do you know that you've got cancer? He said, my parents took me to this hospital, Kidwai Institute of Oncology. I did not know the meaning of the word oncology, so I wrote it down on a piece of paper, came home and looked at the dictionary. So I know that I've got cancer. In that case, why are you not taking treatment? He said, why should I take treatment? My father says I'm fine. My mother says I'm fine. Everybody says that I'm perfectly fine. And therefore, the psycho-oncologist went back to the mother and said, look, your son already knows about it. And then brought the mother and the son and the rest of the family together, talked about the whole thing, made sure that everybody was on the same page. Okay, and that's how the collusion was broken. So, as you would realize that it is far easier to prevent collusion from occurring. But many times, okay, as a palliative care physician, you'll be in a situation where you've got to face a family where the collusion has already occurred and it is causing enormous amount of emotional upheaval. And therefore, these two cases, the first is where prevention is obviously better, but if it has occurred, then you need to acknowledge the collusion, but you need to do it in a very compassionate way because of the fact that there's no sort of place in trying to give sermons and say, see, this is the mistake that you made. You can say that, but you can say that in a much better fashion. So thank you, Prajakta, for that. Can we have the next slide, please? Just a couple of quick slides. So if you look at the decision making, so you can look at the indications, the evidence, the benefits, the harm, the patient and family preferences in terms of reason, autonomy, fairness. You look at the quality of life and how it will affect the quality of life of patients. And then, of course, the contextual factors. Now, if you see below, is it the truth? Is it fair? Is it beneficial? And will it build goodwill? First of all, although she told me very clearly she doesn't want, I must acknowledge my very, very intelligent and much younger colleague, Seema Rao, for having helped me with this PowerPoint and for the research of the articles. So this is the four-way test of Rotary. Is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned? I've written a little article for Rotary. And therefore, these are some of the things that you could look at in the process of your decision making. So thank you, Seema, for that. Next slide. So the summary is, and then of course, I think we've got a few minutes, maybe 7-8 minutes to do that. It is frequently encountered. You must screen and look at it in terms of a routine assessment. Manifold impact, including distress. Handling collusion requires a specific skill and the basic strategies including creating awareness and enabling and empowering the patient, the caregivers to make informed decisions, to be empathetic and compassionate. So this is my presentation. Of course, the last two slides are the list of references. And whoever wants a PowerPoint can please ask for it and Nisha can handle it. So with this, I will stop my lecture, Baji, and I am very happy for anybody to make any comments or to ask any questions. And I would request Arun to kindly coordinate this in the few minutes that are left. Thank you.
Yes, thank you, sir. Thank you for the nice presentation. So I'll start with the chat box from the beginning. So Dr. Rajan Negi asked a question. Can holding back diagnosis from a patient who is having a history of severe depression and now has life-endangering illness, can that be justified? Could you understand the question?
Yeah, I understood the question. I think we have got some psychiatrists on the panel here, including my Guruji, Dr. Chaturvedi. Would you like to answer, Santosh?
Yeah, good morning. Am I audible? Yeah.
Yes, you are.
Yeah. So I think one should also think that one of the reasons for depression might be collusion itself, because the person is having such advanced disease and suffering and does not know what is going on, and there is a conspiracy of silence. That itself can increase depression. But depression should not be a contraindication. Depression can be treated. After breaking collusion, there are three possibilities. Either the depression will become less if it is because of collusion, and there will be more trust and involvement of the patient, or it might become worse for some time as a natural reaction, in which case it can be dealt with. Or like I said, it is a coexisting thing, nothing to do with the disease, in which case it needs to be treated. So one should, unless a person is in delirium, or so severely psychotic that cannot participate in a communication, in which case one should wait till the condition improves. One should still go ahead with the steps which Dr. Simha has mentioned, how to deal with it.
Thank you, Santosh. Grateful to you for adding this. Yes, Arun.
So the other comments are mostly about the two cases. So when we were discussing the cases, people were putting down their comments. And apart from that, I would request everyone to put in questions over here. Still waiting for the questions. Anyone can please ask questions if you have any. You can unmute and ask Dr. Nagesh as well.
Santosh, would you like to add anything, please, on this? I'll be very happy.
I think you have covered all the aspects very well, and given a background of theory also for collusion, because it's one of the types of collusion which you did not mention. I think deliberately was a collusion between physicians and the professionals themselves. They try to keep information away from the patient and their relatives, because of their own dynamics or because of various reasons. But it is a challenging situation, but that doesn't mean that it should not be handled. And if it comes with practice, and make it a habit that one should improve communication between family members and the treating team, so that it is actually good in the end for everyone. And people are reluctant to break collusion because of the same reasons as the family, that the person will break down and what will happen, and might not devastate it, might not be able to take it. But in a controlled situation, in a hospice or in a palliative care center or in a chamber, it can be dealt with by the same ways by which we have been talking about how to deal with communication skills and how to deal with the difficulties which are there. In the end, it is a very satisfying experience if we are able to improve communication between the family members after breaking collusion. Thank you, Nagesh. I think it was a wonderful presentation, and you gave both the theoretical part as well as the practical part of dealing with collusion, so that people can understand what is the theory behind it and how to deal with it in very simple ways. Thanks, Nagesh.
Thank you, Mike. Thank you.
Dr. Nagesh, just 1 minute.
Yes.
In fact, in my comment, I was exactly meaning what Dr. Chaturvedi spoke about, that barriers to this communication is because many times the patients, when they come to our palliative OPD, they have absolutely no clue about this. I mean, making us believe that there has been no communication from the physician.
No, I agree with you, Ganpati. My reference was to the comment about that juvenile diabetic is not about palliative care.
No. It was one before that. That's what I'm saying. It was not meant for the case. As you're talking about the theory, that time I had put it.
Perfectly fine. I agree with you.
Thank
Absolutely.
you so much, sir.
Absolutely.
Thank you.
Can
I have a question? I have a
I had
question, sir.
Go
Can
ahead,
I?
Dr. Mona.
Okay. It's just many a times it so happens that the family is fiercely against the patient knowing about the diagnosis. Although I do sit down with the family to explain the importance of why the patient should know. In spite of that, they are always saying that no, it is best the way it is. And these situations I've often come across. In fact, most of the times, I still am dealing with a young boy, like I've mentioned in the chat box also, that he's also lost his eyesight due to the metastasis, and the family, the elder brother and the mother, they are so fiercely against him knowing what it is, and the boy is still living in a false hope that his eyesight might return and he will get better. So he is living in that situation which I feel very guilty about. In fact, I feel guilty about the boy not being aware of the situation. So how do you deal with such in such times when you so much want to? You've discussed with the family, you've told them the benefits, yet they are fiercely against the boy knowing about it. How do you go about that? Because it bears down on you on those things.
Yeah, I agree with you that it's a major problem, and one will feel guilty about it. But I think it's just that you've just got to go along and handle the situation. The family members would probably require a few sessions of reassurance and to kind of assess what not telling the boy is concerned, how is it affecting the family. In our society, it is very, very difficult to rough ride over the family. I do appreciate that. And you've just got to play it by the ear. I don't think anybody can give you a straightforward solution. Any comments on that, Santosh?
Yeah, no, I think Dr. Mona Rai has asked a very important question and drawn attention that, see, this is what will happen to physicians, that they will be left with guilt, and so it needs to be dealt with. And this is what can be shared with the family in this case, that they will be left with the guilt also if they do not discuss this openly. And tomorrow, when something happens to the young boy, they will be left with the guilt that we did not, do unfinished business. We did not clarify so many things. So they should be aware of that also. And that many times it is the fear that how to deal with it. And that is what we, as Dr. Simha said, we should reassure that we will deal with the reactions which happen and make sure that, the things don't get out of hand. It is a challenging thing. But the guilt not only amongst the the doctors and nurses, but the guilt amongst the family members is also something which is very important, and they should be aware that they will have to live with that guilt, and that will cause a very, very severe grief reaction after that, and there is something which is avoidable.
Yes, and that's
I had a question.
Quite often. Yeah, please go ahead.
So I had a question. This is regarding Santosh sir's extension of collusion between physicians. And I had a case wherein, am I heard, sir? I'm sorry. Am I clear?
Yeah, you're heard. Yes.
Yeah. So I had a case where there was a patient, young patient with advanced cancer. She had a cancer which was in a curative intent, I'm sorry. And she had overdose of the medicine which was prescribed by the pharmacist, prescribed by the doctor, but the pharmacist overdosed her. The patient naturally was deteriorating and declining in a health condition, and the primary team felt that they had no role anymore. They decided to transfer the patient onto my care, but at that point in time, the information about overdose was not divulged or documented in the system. And I got to know of this because when we had a family meeting with the primary consultant post-transfer, I got to know of this information of overdose. Now, I was in a very precarious position because it's a medical legal issue, and I'm being transferred to look after this patient who is in, almost in the dying situation, and wherein family's hope is still latched on to curative, which is acceptable, and wanting to do all in all, go in for ventilation and supportive measures because they still feel that the drug effect will wear off in a couple of weeks, and definitely the patient will revert to normalcy. But this situation, I was in a very precarious situation, and how do we deal with the situation, and how do I come back, as in how do I kind of, protect myself from this issue? As in, of course, I would say I was innocently or ignorantly, involved in this, but how do I protect myself and get out of this situation? And how do I, because this is important in medical legal world, isn't it?
Yeah, I suppose, if you have come to know about it, you need to document that. And from my perspective, I would talk to the administration and talk to the physicians, and to say very clearly, whoever it is who has suppressed this information, that, as far as you're concerned, since you're aware about it, that you're not going to continue with that collusion, right? Now, whether you're going to call the relatives and say, look, this has happened and this is what it is obviously you might not want to do that. But I think documentation will be required to make sure that from your side it is not the same. And would you be required to talk to the family members and say that this is what I have come to know about? Really very, very difficult to say. Theoretically, you can say that you must, but on a practical approach, I really don't know.
I think this aspect we will talk in the next week by Dr. Simha Rao Shrikant. So I think you will get the answer next week. And now we are already, it's such a wonderful lecture, and we have gone 3 minutes beyond our time. Dr. Nagesh, we have to stop here, but this was a wonderful explanation of collusion. And I just want to add one more thing, that if we will allow collusion to happen, this will not only affect the patient's family member, but it will grossly affect the physician, as Dr. Mona has explained very well in her example. Plus, it will also affect the management plan, and this really disrupt the management plan. So till the time there is no transparency between all the caregivers as well as the patient, I think always patient management will really grossly affected. As you have given the first example of diabetic in juvenile diabetic, I think this is a very good answer to the patients and the patient and the sister. We can say that if we are not going to explain to the wife, this will grossly affect his management plan, and ultimately it is going to be, one day it will be life threatening. So either you disclose or I disclose, it does not matter, but we should disclose to the wife so that she will be the best person to take care of the diabetes very well lifelong. So if she's a pativrata or istri, as Dr. Nagesh said, she will stay back and she will take care of the diabetes, because it is not a big problem. And if she is a modern girl and she does not want, and she feels that she is defeated, she will leave the husband, but it will not be a life-threatening situation for the husband. So this is a very important aspect, that collusion should be handled very well. And now Dr. Nagesh has explained so well in whole of the 40-45 minutes. And I think all the students and the young palliative care physician must have got very, very important. I think you have given so many important points, bullet points to that, how to handle collusion and why it is important. So next week, Dr. Shrikant, you will get the answer from Dr. Simha Rao's lecture for your question which you have asked. Thank you very much, Dr. Nagesh. Have a nice weekend, everyone. Thank you, Arun. We are so fortunate that so many brilliant faculty of this country, they are taking lectures. And I am really, really thankful to everyone. Dr. Nagesh, thank you very much. Nisha, Arun, and everyone who got up at early, before 6:30, 70, 80 people have joined. I think we should be, it's so encouraging. Thanks a lot. Thank you very much, Dr. Nagesh.
Thank you, everybody. Good luck. God bless.